almost a year now. So I actually work in child and adult psychiatry. So I pretty much deal with clients of all different ages and backgrounds. So pretty much as young as 4. And I guess the oldest one I've treated so far, I think was 84 or 81 from one of the clinics. So my goal for this really is to, introduce a pretty complicated subject, but make it digestible for you guys. So you can really understand it and apply it to your practice. I know that there is going to be some neurobiology here. So some of you guys who are scared about seeing brain scans and but my job here is to simplify it in a way. And we're not really going to focus on the name of the medication because those can always change. But if I can get you to understand the mechanisms of each medication, whatever new med comes out next year or next month, and once you kind of realize what the mechanism is, you'll have a better understanding of what the side effects are, right? What it's for, and there's a general idea of how it works in the brain. All right, so I guess we can go to the next slide, slide number 2. Excellent. All right. So this is the brain. I figured this is a good slide because it kind of gives you an understanding of all the areas here. So each area is actually implicated in different disorders. So if you look at number 13, which is the frontal lobe, so frontal lobe actually plays a big part in a lot of the illnesses that we have. Now, it's very challenging because a lot of illnesses have cognitive dysfunction, right? It could be schizophrenia, it could be depression, ADHD, anxiety. And that frontal lobe really is not working correctly. So a lot of the medications that we use to kind of fine tune the frontal lobe, right, is your ADHD medications, right? Stimulants, right? Acts on dopamine, acts on serotonin, acts on norepinephrine. And another important area is actually temporal lobe, number 2. Ennis, can we make this interactive, or can someone like chime in? I like it to be interactive. Does anyone want to answer what they think is implicated in number 2? So it's near your ears. So people who have schizophrenia tend to have what? Auditory hallucinations, right? So number 2 is implicated in auditory hallucinations, right? It's pretty on. And anyone want to take a guess on where you would see visual hallucinations? What part of the brain that is by number? Anyone want to take a crack at it? Yes.
Number 1.
Very good. Number 1, occipital lobe, right? So which is why a lot of times patients who kind of get hit in the back of the head, right? I always ask that during interviews, right? Did you see stars or did you see anything, right? So a lot of times back of the head trauma from boxers or sports, that can cause visual hallucinations too. Anyone want to take a guess? What is the most common hallucination? What type is it?
Auditory.
Auditory. Very good. Yep. So 80% of hallucinations, we believe, are actually auditory. So if someone starts saying that they have visual hallucinations, I always want to rule out substance use, right? I always want to rule out organic causes or trauma, right? So I'll order a scan for the brain to make sure there's no trauma there that they're not aware of. So there could be scarring in the brain sometimes that can cause visual hallucinations, right? Or they can be withdrawing from benzodiazepines, they can be withdrawing from alcohol, and that will also cause visual hallucinations. It's very interesting. So someone who's withdrawn from alcohol, actually, they have this very strange visual hallucination where they see little people. Has anyone ever heard that before? I see little people. Okay, so that's a clinical sign. When I was working in an inpatient unit where we saw a patient who had a very high blood alcohol level, and when they were not getting alcohol anymore and they were withdrawing from that substance, they would actually start saying that they would see little people running around the room. And once they kind of say that, you can kind of assume that they're withdrawing from the alcohol. Interesting clinical tip, right? Okay, so we're gonna go to the next slide. We're gonna go back to this later on. I'm gonna go referring back to each slide just to kind of put everything together later on. So this slide is kind of like an oversimplified view of how we believe schizophrenia works, right? If you look at the numbers there, we have 1, 2, 3, and 4. So those are the major pathways of dopamine. Anyone know what dopamine does and kind of like what it's implicated in? You don't want to answer? What is dopamine?
Like the happy hormone?
It is a happy hormone. Yep. So people who love cocaine, they love cocaine because it's a very strong dopamine agonist, right? So what it does is, if you look at number 1 there, it says VTA to nucleus accumbens. So nucleus accumbens is actually a reward center of your brain. And VTA, which stands for ventral tegmental area, that's actually where dopamine is made. So patients who have a substance use disorder, they tend to have a very active pathway in number 1. Right? So let's say you give them cocaine, the VTA is going to produce more dopamine. It's going to innervate that area, number 1, nucleus accumbens, right? Now, this ties in with schizophrenia because that area also is where we believe that where the hallucinations kind of stem from. So when someone has auditory hallucinations or any type of hallucinations, we believe that it's a hyperactive track number 1. So the VTA is producing too much dopamine, and it's actually innervating that area right there, nucleus accumbens, right? So when I give someone an antipsychotic medication, what I'm actually doing is I'm actually dulling down their ability to feel pleasure in a way. So a lot of times when patients are on antipsychotic medications, one of the common side effects is they say, you know what, I'm not hearing any voices anymore, but at the same time, I can't feel pleasure. They have a very flat affect, right? I'm sure you guys see that a lot, right? Things that I used to enjoy doing, it just doesn't feel the same anymore, right? So it's interesting, but I like to call Haldol, which is a very strong dopamine blocker, it's the anti-cocaine, right? People don't abuse it. They're not going to overdose on Haldol. They're not going to abuse it because they know that if they take too much of it, it's going to flatten their affect. They're not going to enjoy taking it, right? Another important area is number 2, prefrontal cortex, right? So frontal lobe, right, which is your prefrontal cortex, has to do with executive functioning. So what do you think, what symptoms of schizophrenia do you think actually happen in that area of the brain? What would we see there? Anyone want to take a guess?
Like sight not listen or not making any sense?
Yes, good. So it would be executive functioning, right? So that could be disorganization. A lot of times patients will say, you know what, it's hard for me to plan stuff. It's hard for me to, oh, very good, and memory and organization. Excellent. It's hard for me to remember things, right? So I can do short-term memory tests with them, long-term memory tests, and they just can't focus. I have this problem a lot with my on-track clients because sure, I have their hallucinations under control, but what about the number 2, the negative symptoms of schizophrenia, which I'll be honest, we don't really have good treatment for that at the moment. So that's one of those dilemmas that we have is schizophrenia has so many components to it, right? You have the positive symptoms, which everyone sees, right? And you have the negative symptoms, what that person kind of experiences themselves, which is the social withdrawal, not showering, disorganization, not able to focus and do things. And actually, if you look at the studies, the negative symptoms are actually the most disabling. That actually what stops people from being able to go out and get a job, go to school, make friends. People are actually willing to compromise still having voices and not give up that cognitive dysfunction, if that makes any sense, right? Because you can kind of, if the voices aren't that strong, you can kind of know that they're not real and you can distinguish that. I guess the more chronic schizophrenics, it's hard for them to distinguish what's real and what's not. Now, another dilemma that we have too is imagine someone who's been having auditory hallucinations their whole life and all of a sudden they get treatment and we stop those voices. Some of them actually get depressed. Why do you think that is?
Because the voices become part of them.
Exactly. So that's something that we should always be aware of also, right? So one of the keys when it comes to diagnosis in the DSM is that it has to be impeding your ability to function, right? That's very important. So some can have auditory hallucinations and they're able to function. They're still able to hold jobs, they're still able to have a family and go out with friends, and that's fine. When it becomes impending and they can't get a job and they can't focus in school, then of course, then we would want to treat that, right? What about number 3? This is kind of challenging, but what do you think number 3 is implicated in schizophrenia? What kind of aspects of the disorder do you think?
Can that be speech?
No, actually not speech. Take another guess.
Auditory?
Close. Yeah, it is close to the area. It's actually, so the substantia nigra and the striatum. So striatum is the area that's for movement, right? So dopamine is implicated in movement. So when you're moving your arm smoothly, right, and you're making these fine motor movements, your brain is actually releasing dopamine. So a lot of times when you're blocking dopamine, what do you see in those patients as a side effect? You see EPS, right, extrapyramidal symptoms. They might get stiffness. They might have cogwheeling. They might have these involuntary movements of their arms, of their neck, of their back. So that means that you're blocking too much dopamine there. So the dilemma that we have with the psychiatric medications is, how can I fine tune the dopamine in those different pathways? Because some of these pathways need dopamine. How can I keep dopamine in number 2, which is the prefrontal cortex we're needing for focus, and block number 1, and at the same time not decrease dopamine in number 3, right? At the same time. And I'll cover number 4. Number 4 is actually prolactin. So this happens a lot in men. So when you block dopamine in number 4, right, increases prolactin, men can grow breasts, right? They can start lactating, women can lose their period. So a lot of times what I'll do is if patients on long-term dopamine blockers, I'll order blood tests to check their prolactin level. And if their prolactin level is elevated and they're having those symptoms, then I would obviously have to address it. We can either change medications or I can lower that dose, right? All right. Next slide. Did it make sense? Does anyone have any questions? Was that a simple explanation for everybody? Good. All right. So this is another pathway. This is the serotonin pathway. So serotonin is a little bit more complicated actually than dopamine because serotonin interacts with all of these other neurotransmitters. So if you look at the raphe nuclei right there, which is like in the middle of the midbrain, right? That's where most of the serotonin is actually created, right? So when someone who's depressed, we believe that there's not enough serotonin that's innervating the neurons there in the raphe nuclei. So a lot of the antidepressant medications that we use, actually what it does is it's a way of keeping serotonin in the synapse. So when we have enough serotonin, so you look at the cortex, which is the gray matter of the big part right there, which is the red circle area, right? So notice how much of the brain is actually innervated by serotonin right there, right? So serotonin is a very important neurotransmitter in our body. We're gonna go back to that a little bit later on. Anyone know what the amygdala is? Amygdala? Anyone want to take a guess what that's for?
It has to do with fear.
Yes, fear is there, yep. So emotion, right? So someone who has a very hyperactive amygdala is someone who might have PTSD, they might have general anxiety disorder. So in essence, so if you look at where the raphe nuclei is, you see how it kind of circles around the amygdala, it actually even connects to it. So serotonin does the opposite to amygdala. So it actually dampens it down a little bit. So what we're doing in essence is if someone has PTSD, has anxiety disorder, or even depression, when you increase the serotonin in the brain, it actually tells the amygdala to quiet down. So it quiets the amygdala down in a simplified fashion. Okay, next one, next slide. Okay, so this is the basic functional unit of the brain. This is the neuron. We'll just go over it very quickly. So if you look at the most important part is actually the soma, which is the head of the neuron. So the soma is actually where a lot of the medications work. So that's where all the genetic material is. And then as the neurotransmitters actually get released. So what happens is, think of the brain as just maybe a million or billion neurons just connected, right? So these are the functional units. So when you give someone a medication, in essence, you're actually working in a microsystem, which is this right here, right? So this neuron is going to communicate with another neuron and therefore keep going. But know that we also have very long neurons. So actually the raphe nuclei has a very long serotonin neuron, where it actually goes all the way up. It's very long. So some of them are short, some are long, and this is where pretty much all of the work goes to with the medication, right? And if you look at the Schwann cells, does anyone know what disease actually degrades that area and causes issues with a person? It can cause psychiatric issues. Anyone know? Anyone take a
Is
guess?
it Alzheimer's?
No. It starts with M. S, multiple sclerosis, right? Yes, very good, right? So what happens is this. So if you look at the Schwann cells that lines that neuron, that's kind of like the insulator of the neuron. So when those Schwann cells kind of degrade, there's also electrical impulses that go through there. So a lot of the electricity that goes out kind of spreads out, and then it doesn't propagate to where it's supposed to go. So that's when you have these symptoms of that illness, right? Okay, next one. Okay, how do neurons communicate? So pretty much it starts from the cell body of the first, so we'll call it the presynaptic neuron, right? It goes from one. The dendrites are where the receiving of the neurotransmitter from the other neuron. It goes down, action potential, which is actually an electrical current. It goes to the terminal junction, and that's where the magic happens. Terminal junction is where the neurotransmitters work, right? So when you give someone a medication, it's working at that area, which is communicating to the next dendrite and so forth, right? And Schwann cells, another name for it's called myelin sheath. So myelin sheath is the insulator of that neuron. Any questions so far? Nope. All right, excellent. So we'll move on. Okay. So this is pretty much an enlarged version of how a neuron communicates with a neuron. So look at SSRI. So this is pretty much in essence how an SSRI works, right? So those little black circles that you see there in the synapse, those are little serotonin neurotransmitters, right? So when someone has depression, anxiety, OCD, there might, I'm going to take a guess, there's probably about 30 in there, serotonins. Let's say arbitrarily there's just 5 there, right? And that's not enough. So if you see those little circles inside with the presynaptic neurons, see those little vesicles there with about 5, it looks almost like a bowling ball. Those are serotonin neurotransmitters actually encapsulated in there. And those are reuptake inhibitors. So reuptake, the brain is very fascinating because it doesn't waste. So it's like recycling. So what happens is when those neurotransmitters from the presynaptic neuron actually goes down to the second one, and after the work is done at that second neuron, those little vesicles actually suck it back up. See where it says 5-HT? 5-HT is another simpler way of saying serotonin. So it kind of sucks it up, almost like a Dyson vacuum, right? Sucks it up, puts it into the vesicles until it needs to be used again. right? So in essence, one way for us to increase the serotonin there is actually shutting down that vacuum, which is 5-HT. So when you shut down that vacuum with that reuptake pump, what happens is more serotonin actually stays in that synapse. Therefore, that's where the clinical effect happens, right? Now, an interesting question is people say, okay, so if depression was as simple as increasing the serotonin in that synapse, why doesn't the medicine work right away? Anyone want to make an hypothesis on why that doesn't work? I'm curious. I'm gonna explain it later on, but I'm curious. Why does it take 4 to 6 weeks for SSRIs to work? You want to take a guess? It could be.
I was gonna say it needs to take time to absorb into the bloodstream, or the blood system.
Close. Anyone else want to take a try?
Does the body reject it at first?
That's a good point. Actually, no, it doesn't. So what happens is a lot of the things that happen remember when I mentioned the soma before with the genes and the DNA? So a lot of the work of the medication, it actually changed the genetic makeup of the following neuron. And that takes a lot of time, which we're going to show in the next slide. It takes a lot of time. So which is why sometimes it takes about 4 to 6 weeks for the medication to work. Some people, it works a little bit faster. If it works faster, what is that called? It starts with a P. It's called a P effect. Placebo effect. Right? Everyone heard that term before? Which is very big in children. So I work with kids also. So when I give a kid a medication, it's a very interesting phenomenon. It happens a lot more with kids, where you give them a medicine and right away they'll tell their parents, you know what, mom, I feel amazing. I feel great. I don't feel depressed anymore, right? Which, that's great. The placebo effect is a strong effect. And I've yet to find studies in which when they use randomized control trials where people use placebos and the actual active ingredient, and there's zero effect with placebos. It's very interesting, but placebos do have a very strong effect. But that initial effect is actual placebo effect. It takes at least 2 weeks for the actual neurochemical changes to happen in the brain. All right, so next slide. So important neurotransmitters of the brain. So I'm going to go over, there's actually a few more, but I figured we'd just use the most basic ones right now. So we have serotonin, which I talked pretty in depth about, right? That's involved in depression, anxiety, schizophrenia, obsessive compulsive disorder, impulsivity. Then we have dopamine, which is involved in schizophrenia, addiction, tic disorders, depression, mania, ADHD, and also aggression, right? We have norepinephrine, which is also involved in depression, ADHD, pain perception, and anxiety. GABA, which is involved in sleep. It's interesting because I actually went to the pharmacy and they were selling GABA pills from a brand. It was like chewables. I don't know exactly how much GABA was in there, but it's interesting they have it actually in supermarkets now for sale. And they have glutamate, which is implicated in schizophrenia, depression, addiction. So glutamate modulation is actually fairly new now. It's kind of like the new frontier in psychiatry. If you guys didn't know already, a lot of the medicines that we've been using have been around for about 70 years. And a lot of the new medicines that we have now, we call them Me Too medications, right? So they haven't really changed in their the ability and how they work, which is why in the beginning when I said I'm not going to go over names per se, but I want you to understand the mechanisms, because a lot of these mechanisms have been around for so long that if a drug rep came to me and told me about a new medication, I don't want to know what the medication is. I just want to say, you know what are the mechanisms of action, right? What does it do? What receptors does it block? How is it metabolized? And so forth. And once they give me that information, I can make an educated kind of guess on what it's going to do, what the potential side effects, right? So it's kind of like a roadmap to easily understand how things work. It's also like learning a language, right? Psychopharmacology is its own language, and we use a lot of these fancy terms. But I'm hoping that after this lecture, you can kind of understand what some of these terms mean in a lay fashion where you can explain it to your clients, right? Okay, so I guess we'll stay here for a little bit. So I put them here very simply, but just because it's involved in certain things, it also depends on the amount of serotonin, right? So low serotonin would be involved in depression, right? Low serotonin would be involved in anxiety. In schizophrenia, actually, we believe that there's hyperactive serotonin in the brain. That's what's going on. OCD would be low in serotonin, and also impulsivity. Dopamine, right? Dopamine is very high in schizophrenia, which I said in the mesolimbic area, right? It's hyperactive. That's what causes the auditory hallucinations. Dopamine is also implicated in addiction, right? Cocaine, amphetamine use, people who abuse ADHD medications, right? Tic disorders. Dopamine can either be too high or too low in tics. So sometimes someone might not have a tic, but I put them on a strong dopamine blocker and actually exacerbates the tic. It kind of awakens it. So that's how I know I need to actually make an adjustment in that medication. Depression, low dopamine. Mania, high dopamine. So if you notice, medications that are prescribed for actually psychosis is also used in mania, right? We also use aripiprazole, we use Risperdal. All those medications that were actually made for schizophrenia are being used for mania now. So in essence, you can kind of almost link psychosis and mania almost the same thing, which makes sense because in a clinical fashion, it's very hard to distinguish mania from psychosis, right? Does anyone ever have that problem too, where some people kind of get diagnosed with schizophrenia and it's actually a very severe bipolar 1 disorder, right? Happens a lot, which is why there's a lot of overlap when it comes to treating the systems. As a psychopharmacologist, I don't really focus more on diagnosis per se. I look more at the symptoms and the overlap of the dimensions, right? Like I mentioned, the dimension of cognitive disorder, which is in the front of your brain, that kind of it spans through a lot of different diagnoses, right? ADHD, depression, schizophrenia, right? Mania can also cause cognitive dysfunction. So in essence, if I treat that cognitive dysfunction, it doesn't matter what your diagnosis is per se, I'm still treating you, right? If it makes any sense. Aggression, too much dopamine, right? Which is why some kids who are very aggressive, I hate to use it, but sometimes I use it as a last resort. We use an antipsychotic medication, kind of helps calm them down, right? Norepinephrine. So norepinephrine is used differently in the brain and different parts of the body. So norepinephrine is kind of like the neurotransmitter that's involved in fight or flight response, right? So when you have that fight or flight response, you have very elevated norepinephrine. You have elevated blood pressure, elevated pulse, you're breathing fast, your adrenaline is up, right? So a lot of people have depression. Sometimes we have different forms of depression, right? Some patients have allergic depression, right? They feel sad and their main complaint is, you know what, I can't get out of bed all day, right? I'm just too tired. I can't focus. So that would be, for me, instead of prescribing them a selective serotonin reuptake inhibitor, right? I can use a selective serotonin and norepinephrine reuptake inhibitor, right? Like Effexor or Cymbalta. So if you look at these neurotransmitters, that's kind of like how you understand why certain clients are on certain medications, right? SSRIs are really good for patients who have moderate depression that doesn't have a lot of anergia, doesn't have a lot of problems with their concentration, doesn't have a lot of problems with their avolition. Once I notice that's their main problem, they can't motivate themselves, they can't focus, they have low energy, automatically I think of SNRI, Effexor, duloxetine, bupropion, right? Wellbutrin, right? It's also used off label for ADHD medications. So if you kind of look at those medications, if you open up that fancy pamphlet that a lot of the meds come with, you open it up, it ends up being like the size of your floor, like a carpet. That's pretty much, it explains the meds neurochemically, but also explains what does it do. Is it a serotonin agonist? Agonist means that increases the amount of serotonin. Is it a serotonin antagonist? Antagonist means that it blocks, right? And if you look at dopamine also, right, it does it the opposite. So if you kind of understand what each neurotransmitter does, you can easily break down and understand each medication class. All right, so we can move on to the next one. Okay, mechanisms of actions of psychiatric medication. So all meds that we use in psychiatry work on these 5 mechanisms. It looks pretty simple, right? So 1, they block the reuptake pump, SSRIs, SNRIs, right? Or Wellbutrin, which is a DNRI, right? Dopamine norepinephrine reuptake inhibitor. 2, they bind to G proteins. Notice where I put slow, fast, moderate, moderate. Now, slow means it takes a long time to work, right? So SSRIs take a very long time to work. It blocks the reuptake pump. G protein also is very slow to work, right? Number 3, binds to ligand. Anyone want to take a guess what binding to ligand, what kind of medications work fast? Want to take a guess on what type of meds that would be? Starts with an X. People love to abuse it.
Xanax.
Yes, very good, right? Xanax very fast. Someone's very anxious. They're going on a flight. They're going to make a speech. They're going to do a presentation. They ask for Xanax, right? Because it works very fast and it doesn't last very long, only for a few hours, right? What about number 4? Binds to voltage-gated ion channels. It sounds very fancy. What do you think that is? You want to take a guess of a medication that works on that? I'll give you a guess. It works on seizures also. Mood stabilizers, right? Depakote, lamotrigine, right? Carbamazepine, those medications, right? Moderate, I say about 1 to 2 weeks to really start working effect. So lithium is technically not a voltage-gated ion channel, even though it's kind of lumped together with those anticonvulsants or mood stabilizers, but it's actually its own beast. We'll talk a little bit about lithium later if we have time. And number 5, inhibits enzymes, right? So our body has enzymes that kind of break down neurotransmitters, right? Because if you have too much of it also, you can get psychosis, right? Too much dopamine. If you have too much of any neurotransmitter, it can cause dysfunction in your brain. So in essence, we can actually increase the amount of neurotransmitters by stopping these enzymes. So an MAOI inhibitor, right? We don't really use them as much anymore. Or for Alzheimer's, Aricept is a acetylcholine esterase inhibitor. Acetylcholine esterase is actually an enzyme that breaks down acetylcholine, right? Okay, next one. Important terms to remember, right? I kind of mentioned this briefly. So agonist mimics the body's natural transmitter, right? So it's a medicine that you put in someone's body. It tricks the brain to thinking that it's a dopamine neurotransmitter, right? Or it tricks the brain, it tricks the brain to thinking that it's a serotonin or whatever, so forth. Antagonist is a blocker, right? So someone who has hyperactive neurons, which is causing psychosis, I would give them a dopamine blocker, right? Which in essence is an antipsychotic medication, right? Number 3 is a partial agonist. I'm wondering if anyone knows what can list a medication that's a partial dopamine agonist. It starts with an A. It's a fairly new medication. Aripiprazole, Abilify, right? That's a D2 partial agonist. And another concept we should know is downregulation, upregulation. All right. So downregulation, upregulation is kind of like explains why medicines work for a certain amount of time, then all of a sudden they stop working. The reason why is because our body always strives to kind of maintain homeostasis, right? So if your neuron, if you're blocking it artificially, let's say, for instance, with a dopamine blocker, right? What do you think is going to happen to that neuron? It's not used to not getting as much dopamine it was getting before, right? So a term called upregulation means that it's actually going to get more sensitive to dopamine, right? Serotonin neuron, if you block that serotonin neuron, and it's used to getting a lot of serotonin, what will happen is the body will actually upregulate also. It'll make it more sensitive, right? So that's a good way to understand how side effects might happen later on in treatment. So someone who doesn't have side effects early on, but now they do, that's kind of because their brain is trying to adapt to what you're doing artificially. Our brain wasn't used to having pills put inside and working against what it is, right? Okay, next one. Okay, G protein link, that looks very complicated. You see that? So look at that. So an agonist, right? So let's say you put a dopamine agonist, and all those little drawings that you have, those are actually proteins that are changing in a sense. So by remembering that picture and linking it to G protein link receptor drugs, and you see how complicated that picture is, it'll kind of remind you that if you see a drug and you know that it's working by G protein link receptors, that it's going to take a long time to work. All right, I figured that's a good way for people who are visual learners. If you remember that picture and link it to G protein, you'll kind of understand that any drug that works on G protein will take a while to work. All right, next one. Ligand gated, boom. Xanax works very fast, right? Take it, within 20 to 30 minutes, you're relaxed, right? The downside to Xanax, which I don't like to prescribe it because the medications that tend to work faster are more abusable. So the more Xanax you take, the more you can actually overdose on it, right? A lot of people overdose on Xanax because a lot of Xanax actually shuts down your respiratory centers in your brain and they don't breathe. So almost very similar to opioids, actually. So opioid, yes, a lot of people do overdose on opioids, but from when I was working in the ER, it wasn't just opioids by themselves. It's when you start mixing Xanax, which is a benzodiazepine, with, let's say, heroin or methadone that they were abusing with alcohol, that triple combination is very deadly. Those are the patients that usually don't make it, all right? Next one. Okay, factors that influence drug response, right? Number 1, genetics, right? So everyone's body is different. So a lot of times, sometimes I'll ask a patient, anyone in your family, suffer from mental illness, right? If they say yes, second question would be, are they taking any medications, right? Third question is, if they are taking medications, is that medication effective? Because most likely, if that medication, especially if it's a first-degree relative like a mother, father, brother, or sister, there's a very high likelihood that their bodies will actually respond to that medication also, right? Age. So as we age, our body kind of degrades. Our kidney functioning, right, which is very important to excreting the medications, it tends to kind of get worse. So a lot of times older people, we tend to, I guess 65 and older, we tend to give them lower dose of medications because the effects of it are actually worse, right? They have more side effects, and it actually makes them, it stays in their body also a lot longer due to the fact that their kidneys are not functioning the way they should, right? Diet. Okay, diet plays a big part actually in medications. So It's often overlooked sometimes, but did you guys know that caffeine intake can actually increase the levels of certain medications, like clozapine, which is a very strong medication that already has side effects, right? Does anyone know what grapefruit juice does? If you drink grapefruit juice, what it does to your medications? Anyone know? Do you think it increases the level of your meds, or does it drop?
It
Sorry?
drops.
Finish the impact
It
of
decreases.
antipsychotic medication.
So it actually, yes, increases the amount of medication that you take, right? So if you're taking, let's say, 10 milligrams of a medication and you drink grapefruit juice that morning, you're actually, in theory, you could actually quadruple that dose of medication. Now, depending on what medication it is, if it's a blood pressure medication, you could drop your blood pressure very high. Very low, which could be very dangerous, right? So diet is also very important. I always do a good diet screening when I start patients on medication. I'll always ask them, I'm curious, what kind of diet are you on? Because even high-fat diets can also increase or decrease absorption of medications, right? A lot of people are big into nutraceuticals now, right? People buy stuff on Amazon. They go on GNC. They'll buy all these diet supplements, but we don't really know what's inside because they're not regulated by the FDA, right? Cocaine users drink the juice to feel high. Yes, that's true. Yeah, because it increases the dose of cocaine. Very good, Harley. So I always try to get a very good understanding of their diet. And also if they're going to change their diet, I ask them also, like, I'm curious, if you're trying to lose weight, are you going on an Atkins diet? Are you going on all these different diets? Are you decreasing your carbohydrates? Are you increasing your fats? Because that can also play a role in the medication. Because some medications, they do better in different environments. So let's say, for instance, if you take a medication with food, right? It goes inside your stomach releases gastric acid, right? To break down that food. What happens to that environment? It becomes more acidic, right? So did you know that stimulant medication in an acidic environment actually makes it excreted a lot faster? So if you drink a lot of orange juice and your Adderall was working before and, if you weren't drinking a lot of orange juice and all of a sudden you realize your Adderall is not working the way it should, I'll ask you, are you drinking a lot of high citrusy foods, right? Are you eating foods that are more acidic to your stomach? People overdose on stimulant medication. In the ER, what they do is they actually give you, they pump your stomach with something that acidifies your stomach actually, and that kind of excretes it a lot faster, right? Other medications, right? This is a big one. So sometimes it's very hard to remember the many interactions between medications. There's probably like thousands of them. I know the very severe ones, but sometimes I have to rely on the program. So a lot of times I'll use a program on my smartphone where I'll put two medications that will actually tell me what the interactions are going to be, right? So for instance, if I don't like to prescribe bupropion, fluoxetine, and paroxetine with patients who are taking a lot of medications. The reason why that is, if you want to remember mnemonic, I remember it causes big effing problems, right? Big is bupropion, F is fluoxetine, P is paroxetine. What it does is it's actually an inhibitor of the CYP450 enzymes, which I'm going to go over next, which is kind of like what our body uses to metabolize medication. So by inhibiting, it actually stops our body from metabolizing those meds. So it actually, in essence, increases those medications. So people are on those meds, they tend to be on lower doses of the other medications, right? Excellent. So I'm going to go to pharmacokinetics now. So what is pharmacokinetics? Pharmacokinetics is how our body kind of works on medication. So it's the absorption, right? Are you taking it by mouth? Is it being injected? Is it being put through IV? Is it going under your tongue? Many different ways, right? How is it distributed, right? Is it distributed to proteins? Is it distributed to fat cells, right? Metabolism has to do with your kidneys, right? That's a CYP450 enzyme. So our liver actually produces enzymes called CYP450 or cytochrome P450 enzymes. There's about 20 of them, which each medication is actually metabolized by different ones. So if one medication actually inhibits one enzyme for another medication, it actually can increase or decrease the levels of another medication, right? And number 6, the person's belief that it will work, right? So it's very important, especially for me, because I already know that taking medications is very difficult. And I always try to tell the patient or the client that, you know what, you're in charge of taking this medication. And I have seen people take this medicine and I know that it works. People who are skeptical about medications, I won't prescribe them medications on the first visit, right? If someone's already saying, I don't really believe in medications, you know, my mom's taken it, I've seen her get sick, my uncle's been on it, I don't believe in it. What I'll do is, okay, you know what? I'll give you the information, you can read it over if you want to see me in a month, assuming that their condition is not is not that bad, where they can go a week or two without medications. And I'll give them a chance to think about it, because in reality, the worst thing I can do is prescribe someone medication, they walk out, or working from home now and they throw it right in the garbage, or they don't even pick it up from the pharmacy, right? So a lot of my work is educating the clients on, it's part of, it's part of your treatment, but it's not the main part of your treatment, right? So I believe in the 1/3 rule. So 1/3 rule, that 1/3 of treating you is medications, 1/3 of treating you is lifestyle choices, right? Healthy eating, exercise, sleeping on time, waking up on time, right? And therapy, right? So all of us kind of have to work in a team to get this patient well, right? If someone doesn't want to go on a diet, or someone just wants to eat fatty foods, doesn't really want to sleep in a regular schedule, then I always tell them, you know what, then you're kind of depriving yourself of about 30% of recovery. Because as complicated as mental illness is, there's no simple solution to it, right? There's no magic pill that's going to make your depression go away. And in reality, anyone want to take a guess on the first trial of antidepressant medication? What percentage of people do you think actually respond and have full remission to that medication? Anyone want to take a guess?
%? I don't think it's, would it be a high number? Or could
It's
it
actually very low.
number?
It's actually very low. Yeah.
Yeah, I think around 10%.
So a few people put, actually, let's see what the guesses are here. 33%. Okay. Wow. Jeannie. And Diane, 25%. And someone said 5. Okay. So it's actually in between 25 and 33. So anyone here ever hear of the STAR-D trials? It's cited a lot, actually. So it stands for sequential treatment alternatives to treat resistant depression, STAR-D, I'm sorry. And what it did was it had 4,000 people in a large trial in which they were able to see the effectiveness of SSRIs, SNRIs, mixed with tricyclics, and a bunch of other adjunctive medications. And they found that the first medication, which was actually citalopram, only 30% of clients in that trial actually had full remission, right? Full remissions means no symptoms of depression at all, right? So then they moved on to phase 2. Phase 2 means either they switched the medication or they added another medication on top. And I believe there's another 20%. So in general, when everything was said and done, in reality, only 67% of patients actually respond to medications. There's another 30% that don't, right? So I'm very honest with clients when I say, you know what, every time you fail a trial of medication, our chance of getting you in a medication that's actually going to give you full remission gets lower and lower, which is also why treating early is very important, right? Because the more time someone fails in a medication, the less chance they're going to be to actually respond to that next medication, right? So there comes a point where someone becomes treatment resistant. Treatment resistant means they don't respond to any medication, right? So how do we treat that? Anyone want to take a guess?
Counseling. If they're not responding to any medication whatsoever, the next bet will be just counseling.
Yeah, very good, excellent. Yeah, so that's you guys. If I fail, I'm relying on you to back me up, right? So depression is very complicated. It's more than just simplified as not enough serotonin, norepinephrine, dopamine. There's a lot of implications also. There's a lot of there's also cortisol in there. So our endocrine system is also implicated in there. That's probably why a lot of the medications in psychiatry don't just work, because sometimes you need to add like thyroid hormone to actually balance it out. So depression is not just a brain-based disorder. It's also, actually, we're finding out now that our whole body's involved in it also. There's a lot of hormones, like with women, estrogen, right? Low estrogen can also cause depression. And the change in estrogen levels as you get older can also increase or decrease depression risk, right? So what I tell a client is, you know what, my goal is to try to get as much of your symptoms in control as possible. And it's up to you to kind of work out the rest of that with therapy. My main focus is giving you the energy to get out of bed to go to therapy. Some of the analogies that I use is that medication, imagine you're stranded in the ocean, right? And you can't swim. Medication is really just a life vest, right? Therapy is what's going to teach you how to swim to get across the shore, right? People get on, people believe, and maybe it's part of the pharmaceutical companies also, that you can take a medication and make all your problems go away, and you don't need to go to therapy, and you don't need to kind of take ownership of your health, eating better, exercising, meditation, and that's it. But in reality, you need a lot more than just medication. And sometimes people are more sensitive to meds. So if really medicine will help you, but you're sensitive, and this comes to the dilemma of efficacy, right, versus tolerability, right? Some people are not willing to compromise one for the other. Someone will say, you know, I'll take a med that will get rid of 20% of my symptoms, but it's not going to give me diarrhea. It's not going to, you know, impair my sex life. I'll take that medicine over a med that I know will help my depression, but I can't take it because it makes me so sick every morning, right? So I guess our goal is to work in partnership with them and find a med that can improve as much of their symptoms and also not give them the side effects that make them not want to take the medication, right? Any questions? Okay, what are some of the proposed etiologies of mental illness, right? So I'm going to go over just a few basic ones. So I guess we'll talk about psychosis, right, first, because I know schizophrenia is a very complicated disease, and we're still kind of trying to understand it. So schizophrenia has to do with a lot of dysfunction in the brain, right? Will anti-abuse interfere with antidepressants? That's a good question, Harley. Actually, I don't know. I don't know if anti-abuse interferes with antidepressants. I can easily look it up in my app and find it. I do know that anti-abuse actually can cause psychosis. Did you know that's called disulfiram I psychosis? I forgot disulfiram induced psychosis. I use Hippocrates. So Hippocrates is a good app that I pay for every month. And I'm sorry, I'm just answering questions that people are texting me. Then I'm able to get all the answers that I need if I know that there's interaction between the medications. Okay, so schizophrenia, right? So we believe that schizophrenia is actually a very complicated illness that implicates more than just dopamine, right? So actually, a lot of studies that we're using now implicates glutamate because PCP, which is actually a glutamate antagonist, which blocks glutamate, causes symptoms which look very similar to actually schizophrenia. So if someone goes into the ER and they're aggressive, they're having hallucinations, they're paranoid, and we do a drug test and they're positive for PCP, which is phenylcyclidine. I forgot what the P is, but PCP. Once they metabolize the PCP, sometimes the psychosis goes away, and they do sometimes get antipsychotic medications just to kind of help calm them down. So now we know that it's more than just dopamine, right? So a lot of the new medications that we're using now is trying to find ways besides blocking dopamine to kind of help with their psychosis. Because the very first antipsychotic, anyone want to take a guess when the first antipsychotic was actually discovered? The decade. Oh, Nicole, 1965. Close, actually earlier than that. I want to take a guess? 1948. 1948, chlorpromazine was actually first synthesized. It was made as an anesthetic medication, and a lot of the medications in psychiatry are actually kind of found serendipitously, which means that people were trying to make meds for something else, and they realized that it was actually working on other people. So they were making an antihistamine medication, which was actually going to be used for surgeries, and they synthesized the medication before they called it chlorpromazine, and they were going to use it to help people kind of relax and ease them into surgery. And what they realized that when a lot of psychotic patients were getting it, their psychosis were actually going away, right? So the very first antipsychotic was chlorpromazine, and that kind of led to the movement of getting people out of institutions and more into the communities, right? So when chlorpromazine really hit the market, a lot of people were able to function outside because that was kind of like one of the best medications that we had at that time. Now, the downside to chlorpromazine was that they were giving it in very high doses because no one really knew what the safety dose was. So people were violent and they were getting injections of chlorpromazine, probably going up to like 200, 300 milligrams a day at that time. Now people probably only get a fourth of that, right? Because we know that the higher that you go on dose, the more chances you are going to have side effects, right? And then from chlorpromazine, then we had Haldol, and then from Haldol, they moved on to aripiprazole and clozapine. So clozapine is probably the best antipsychotic medication that we have right now. But we keep clozapine for treatment refractory schizophrenia or treatment resistant schizophrenia. So we kind of keep the heavy guns till the very end, and we don't prescribe clozapine until someone has failed on at least 2 antipsychotics. Does anyone here have any patients on clozapine? I'm curious. Anyone? No? Okay. Okay, a few of you do. Okay, yeah. So clozapine is a great medication, but again, it goes with the dilemma that I was mentioning about tolerability versus efficacy, right? So clozapine is very effective. It actually causes something called awakening, which many people who've been a schizophrenic for a very long time or psychotic, when they take clozapine, they're actually back to normal. It's the closest thing that we have to a cure of schizophrenia there is, if someone responds to it. But it causes something called severe neutropenia or agranulocytosis, which actually can kill people. So when you prescribe clozapine, number one, you need to go very slowly. Number two, you need weekly blood work to make sure that their CBC is normal, right? Which is the blood cell count, of their blood, to make sure that they're not having neutropenia, because neutrophils are actually very important in our ability to fight infection. So when someone has very low neutrophil count, right? In essence, it's almost like someone who has AIDS, because they can't fight off infections and they can die from that. So it's very important that they're monitored. If they miss blood work, I have to stop the medication and retitrate them again. And also there's a registry for it, in which it's a national registry in which I need to submit blood work for each client before I can actually prescribe them the medication. And the pharmacy has to verify that the blood work was done with them and that it's normal in order for them to get the blood work, right? But the good thing about clozapine is once they pass 3 months or 4 months, they're pretty much in the clear for that very bad side effect of killing them. But then they also have other side effects, right? Probably the worst side effect is weight gain. Clients tend to gain about 30 to 50 pounds on it. And that's being very conservative, sometimes more. I have a client right now who I have her on metformin twice a day. She actually is running, she actually is exercising, and she's on clozapine, and she can't get rid of the weight. And I'm worried that eventually she's going to give up, because she's 18, and of course body image is very important at that age too. And it's important for me to kind of support her whatever decision she makes, but I also remind her that once you fail, and this is also very important, if you have patients that say they want to stop a medication, I always tell them, sure, you can stop a medication, but it's not guaranteed that when I restart you in that medication, that it will work for you again, right? So I have many patients who are stable on meds. They feel the stigma of being on medications. They're like, you know what, I feel great. And they almost forgot how bad it was before they were on that medication. And now they want to try to go off it. And they go off in the medication, and their psychosis comes back, or their depression comes back, and they go back on the same dose, and it doesn't work anymore, right? That goes back to that last slide when I was talking about desensitization and how the body kind of adjusts to it. Sometimes those changes in your neurons, they don't really go back to the way they are. So either I have to go up on the dose. By going up on the dose, now you're risking side effects, or I have to change the medication, and there's a risk that you might not respond to that medication either, right? Okay, so the next one, we're going to talk about depression. So yeah, sure. What's the question?
But you was just saying how how medication no longer works. So when they're not using those particular neurons anymore and the pathways to release it in the body, that neuron becomes useless and kind of inactive.
It doesn't become useless, but what'll happen is sometimes it's called a drug holiday. You'll stop a medication for a few months, and then hopefully the neurons will kind of readapt to the way they were before. But it's not really realistic in clinical practice, because obviously if a patient stops, let's say Zoloft or Prozac, their depression is going to come back, and you can't tell them, why don't you wait 2 months, not be on medications, right? And then come back to me and we'll try that medication again. So the dilemma is I need to start you on something to help you get back on track, right? So I mean, in theory, in textbooks, sure, drug holiday looks great because the neurons can adapt again. But in clinical practice, it doesn't really make sense, because the client will want their depression to go away. So I'll have to start them on a new med. And that new medication will probably have to be a different mechanism of action, right? It won't be an SSRI anymore. It might be an SNRI, or it might be bupropion, which is a dopamine norepinephrine reuptake inhibitor. Does it make sense?
It makes sense. Because once, it sounds like once that neuron is inactive, it may take a while for it to regain its activity. So something else would have to be in its place in the meantime.
Exactly. Yep. That's what makes sense.
Oh.
So depression. Now we were actually understanding depression as having many different subtypes of depression, right? I know DSM kind of just breaks it down into bipolar depression, MDD, cyclothymia. But if you realize some patients don't respond to certain medications because their depression subtype is actually very different from another person's depression subtype, right? One person might have depression because they might not have enough serotonin. So if you give them a selective serotonin reuptake inhibitor, let's say like Prozac or Lexapro, then sure, it'll work. But if their type of depression is more of a serotonin norepinephrine type of depression, then it's not going to respond to it. I have to give them that, right? Now, there's also depression which has to do with inflammation. Did you guys realize that when you have a flu or when you have a cold and you're congested, kind of like how I am right now, your mood is kind of low? Did you realize that? Right. That's also another subtype of depression. So sometimes what we can do is that you can actually order blood tests for a hormone or a protein, I'm sorry, called C-reactive protein, which kind of measures the amount of inflammation in your body. And if that CRP is a certain level, it kind of gives me an idea of what treatment response might work best for you. We also have genetic testing now. I don't have experience actually doing it myself, only because number one, insurance companies won't really pay for it. And number two, it's not fully validated yet, but it kind of gives a better idea of how we're going to make our decisions. Sorry, someone wrote me a chat. Let's see. Yes. So allergies. Yeah, allergies can also make you feel depressed. So we're looking at depression more now as not just a brain-based disorder. So it's kind of like it's shared through the different specialties, right? So psychiatry, endocrinology, even also PCPs can help in managing depression. So a lot of times medicine can also stop working because there could be an endocrine disorder. Anyone want to take a guess on what type of endocrine disorder can mimic depression? I'll give you a hint. It's on your neck. It's in your neck.
Thyroid.
Yes, thyroid. Very good. Low thyroid, right? So sometimes if you don't treat that underlying hypothyroidism, the antidepressant medications actually aren't going to work. So there are points where I'll order labs every 6 months, but I'll order labs for a full general idea of what the general health is of that patient or that client, because I want to make sure that their thyroid is functioning. Because if they have subclinical hypothyroidism, right? Subclinical means that the lab will actually say, let's say the cutoff is 0.3 to 2.5. Their thyroid is actually 2.5, which is normal. But in reality, anything above like 2.3 actually causes problems with depression. So that's when I'll actually treat it. I'll give them Synthroid to treat the thyroid issue, have them follow up with their PCP to check for anything else, and actually their depression will go away, or their antidepressant that stopped working because the thyroid issue will actually start working again, right? The next one I'll talk about is anxiety disorders, right? So anxiety is very similar to actually depression. There's actually people that are arguing that they're almost the same disorder because a lot of the parts of our brain, which is the amygdala, our dorsolateral prefrontal cortex, a lot of those circuits are actually implicated in the same disease. Because did you know that SSRIs work for both? Did you know that SNRIs work for both, right? A lot of quote unquote antidepressant medications are actually better anti-anxiety medications. Did you know that? So when people use terms like antidepressants, I use it too, because kind of like when I was training, that's what we were using. But I try my best not to classify meds like that anymore, because even antipsychotic medications are used. If you notice, they're used in many different disorders now, right? So you'll see someone who has depression will actually have a quote unquote antipsychotic medication, right? Or will be on an SSRI and be on aripiprazole or be on quetiapine or olanzapine or any of those medications, right? Because that means that our understanding of mental illness relating to one neurotransmitter is actually expanding to more neurotransmitters. Okay, someone said, is it safe to take hydroxyzine and Zoloft at the same time? Yes, it is. It is. But the thing about anxiety disorders is that you need a much higher dose. So let's say, for instance, someone comes to me with GAD and I prescribe them Prozac, right? If they had come to me for depression and I prescribed them Prozac, they might be fine on 20 milligrams of Prozac, right? No problem. But for anxiety disorders, if they just have GAD, I would have to go much higher, right? And it also takes longer for it to work. We don't really understand the exact mechanisms. We do believe that maybe it just takes longer to actually quiet down the amygdala that's overfiring. So what I'll tell a client is, if I'm prescribing you an SSRI like fluoxetine for anxiety, give it at least 6 to 8 weeks, and don't be surprised if we go higher than what you've normally been used to for seeing for people with depression, right? So anxiety disorders have to do with a hyperactive amygdala, right? Firing very fast. Even someone who has PTSD, right? What does therapy do? Therapy teaches you how to kind of train your thoughts to quiet down your amygdala, right? So cognitive behavioral therapy, right? Exposure therapy, right? Regulating emotions. Yep, very good. Yep. So in reality, if we did a brain scan on someone, right, who's actually having cognitive behavioral therapy for general anxiety disorder, or someone who's taking an SSRI for cognitive behavioral therapy, right, the brain scans would actually look very much the same, because it's targeting the same pathways, right? The pathway from your raphe nuclei to your amygdala, which is connecting to your frontal lobe, right? What does therapy strengthen? Therapy strengthens your frontal lobe, right? When you tell a client, you know what, all those negative thoughts, those anxious thoughts, you know, I want you to change them, and I want you to find a way to kind of rephrase them in a way that doesn't cause as much stress to you, right? That pathway that's being innervated by that therapy is actually the same pathway the medication is working on, right? So using that logic, I tell a client, you know what, tell me how engaged you plan to be in therapy, right? If they say, you know, I don't believe in therapy, I don't like my therapist, therapy doesn't do anything for me. So that tells me, you know what, I need to go higher on their medication. And I'll tell them that. If you're not going to be engaged in therapy, the best treatment would be going a little bit higher on your medications. The risks are that there's a higher risk for you having side effects. The more engaged you are in therapy, right, the less dose of medications I can put you on, because it's targeting those same pathways, right? Is that interesting? Now,
Very interesting.
yeah. Now, if you use both, right, if you look at studies for treating anxiety disorders, right, the effect size is actually kind of like the strength of the medication. So for SSRIs, it's actually 0.6, right? The effect size for therapy is actually 0.8. So that means that therapy, in essence, is actually more effective than medications, right? Now, if you give both, then I believe it's a little bit over 1. The effect size is higher, right? So I always tell patients, don't rely on just medications. You got to be active in therapy. You know, if you miss therapy, it's okay, but that's really what's going to get you to swim across the river. All right. I want this to be as interactive as possible. So I want to answer any questions you guys have. If I know the answer, if I don't know the answer, I'll be honest. I'll say I don't know it. But if anyone wants to kind of understand the etiology of another, okay, what about undiagnosed childhood trauma, brain injury? What is the best intervention where MRI might reveal the TBI in childhood? You know what, Maria? That's a great question. I'm actually don't know the answer to that, but I can look it up and find out. But trauma. So trauma is very, the best way to describe trauma to a client is that the earlier the trauma, the more ingrained it is in your brain. So if you look at the brain, the way it's kind of made biologically, it's kind of stacked on top of each other, right? So anyone ever hear of the tri-brain theory? The tri-brain? So you have like the reptilian brain, the mammalian brain, and you have the human brain, which is our cortex, which is on top, right? So let's say, for instance, a client was touched when they were 2 years old, 3 years old inappropriately, and now they have sexual abuse, and whether they repressed that memory, right, and it comes back a little bit later on, that memory is stored in a more primitive part of the brain, which is deeper, the deeper brain structures, right, which is the reptilian brain, or even the mammalian brain, which is the middle of the brain, right? So the medications that we prescribe you are kind of just only touching the cortex for the most part. If you remember that first slide I showed you with all those from the raphe nuclei, which showed a lot of the arrows were pretty much on the perimeter of the brain, right, on top. What about if the trauma is inside the brain, right, very deep? So how do you get that trauma to kind of go up to the cortex and help them kind of deal with it, right? That's where therapy takes over. So what do, right? Freudian therapy. Tell me about your mother. Tell me about your father. They have this memory. Then they kind of talk about it. Then they kind of start processing it. So in general, what that does is it pushes it up to your cortex, right? Which is where we're able to kind of make sense of it. And that's when the medication can work. So which is also explains why the deeper the trauma, the younger they are in childhood that has it, the more severe it is, the harder it is for medication to kind of touch it, right? If that makes any sense. How does etiology work for adults who are substance use users and have mental illness? Okay. Substance use. Substance use really complicates a lot of our treatment, right? So number one, I always try to kind of normalize everyone's substance use, right? I understand why you're taking this medication. If I was feeling this type of depression also, you know, maybe I would be taking cocaine because that's the only medication that's giving me the energy in the morning, right? Did you guys know that the first antidepressant was actually amphetamines, right? Cocaine. So Freud, they say, was self-medicating with cocaine, believe it or not. But, you know, that has its own side effects also. But when you're prescribing someone medication for a mental illness and they're using substances also, all right, like I mentioned before, the substance they're taking can actually counteract. So for instance, if someone's taking cocaine on the weekends and I'm treating them for psychosis, I'm blocking dopamine, but they're increasing their dopamine. So what's happening? They're kind of like blocking each other out, right? And there comes a point in which the medication gets overwhelmed by that influx of dopamine, and the medicine doesn't work anymore, right? So I always try to get an understanding of their use. And I tell them, if you don't stop your use of cocaine or amphetamines, I'm sorry, but your medication is not going to work. And we're kind of in the stalemate of you being where you are, right? So it used to be that if someone had a co-occurring substance use disorder, a lot of old school psychiatrists, they don't treat you. They'll say, you know what, you're using marijuana, or you know what, you're abusing cocaine. I'm not treating you. Go to substance use program, you know, stop the habit, and then I'll treat you. Come back to me 5 months, 6 months later on, right? That doesn't do anything, because it's chicken or the egg question, right? Is your substance use due to your mental illness, right? Or is your mental illness causing your substance abuse? We don't really know. So studies now is you have to treat both, right? So that's why just because someone's using substances, I'll still treat them. I will. I'll treat them with antipsychotic medication. I'll educate them. I might actually have to go a little bit higher on the medication. And then when they have side effects, I'll explain to them the reason why you're having side effects is because I'm putting in your higher dose because you're using cocaine and amphetamines, right? Or you're abusing stimulants. Next question. Can you talk a bit about medication treatments for ADHD, younger children? We need too many parents to not reject medication. Okay, very good. ADHD medication, very controversial. I do believe that sometimes they are overprescribed. Majority of ADHD medications are actually prescribed by PCP, believe it or not, primary care physicians, right? It's very simple. Patient complains of not paying attention or hyperactive. It's very easy to write a script for Adderall or methylphenidate, right? But the downside to that is if you're treating someone who doesn't have ADHD, right, the long-term use of stimulants itself is not safe either, right? And I get a lot of parents that say, you know what, I don't want my child to be abusing medications. I don't want them taking medications so early because I know medications are bad, right? So the studies now that we're showing is that children who don't get treatment for ADHD, who actually do have ADHD, right? What happens is that the stigma of being the bad kid in school, right? You know what, little Timmy, he's never paying attention. He's being teased because he's always moving in his seat. He has lower grades than every other kid. That can be worse than them not being on medications, right? Because now they have that trauma of being bullied in school. The teacher labeled them as the bad kid, and what'll happen? They'll grow up to be the bad kid, right? You call me the bad kid, you call me a bully, so I will be that bully, right? And that's why they say there's such a high comorbidity between oppositional defiant disorder, right? Chronic disorder, all the externalizing disorders, right? And ADHD. Is it because they had undiagnosed ADHD and all of a sudden this caused the progression to that, right? Just something to think about, right? So what I tell parents is that, yes, I do understand your concerns about medications. I'll also explain to that the frontal lobe doesn't usually develop for men until we're actually 26, right? It's a little bit earlier for women, which is men make poor choices early on. And what the medication kind of does is it kind of nudges that development in the right direction, right? Once the frontal lobe is fully developed, a lot of the hyperactivity kind of goes away. The inattentiveness doesn't really go away, but what happens is once people kind of find their niche of a job, right? Once they kind of go to college and they're able to kind of, whether it's accounting or law, even doctors, medicine, right? It becomes to a point where they can find their routine and they can find ways to overcome that inattentiveness without taking the ADHD medications, right? So they don't have to be on long-term ADHD medications. I always tell the parents that as they get older and you notice their symptoms getting better, we can start going down in the dose. Sometimes it remits, right? It just goes away. We can't explain why. We believe it's just developmental. Sometimes it doesn't. But usually I tell them is the dose that gets you well, right, is much higher than the dose that keeps you well. What does that mean? So the medicine that controls your ADHD initially to help you focus and help you keep control of your behaviors, I can start tapering it down. Let's say you're on 20 milligrams of amphetamines. I can keep you in a stable maintenance dose of 20 milligrams once it's stable, and that's less side effects. And then once you realize that the symptoms are gone, then we can actually get you off of it and try, right? Once you learn those social skills, again, therapy, you can actually treat someone who has mild ADHD to moderate ADHD with therapy and still help them without taking medication. So I give parents the option, but there comes a point in which the kid is so hyperactive they're destroying stuff in the house where the stimulant medication really is the only thing that will calm them down. It's interesting, but the way the brain works, so how our frontal lobe works when you have ADHD, it's actually hyperactive, right? It's hypoactive, right? We don't have enough dopamine. We don't have norepinephrine. So we do these risk-taking behaviors and we kind of act out or will do crazy things in life, because when you do crazy things in life and do risk-taking behavior, it increases that dopamine in your brain. So you're kind of self-medicating in a way by doing risky stuff, right? So when I give you a stimulant and you have the proper amount of dopamine, norepinephrine in your frontal lobe, you don't need to do those novel stuff, right? I don't have to jump off the couch. I don't need to climb on top of the bunk bed and jump to make myself excited anymore, right? It kind of calms you down. Now, the side effects of ADHD medications, if you start them very slowly and you use an extended release medication, you can kind of alleviate a lot of those side effects. Most of the side effects really are sleep disturbances. So a lot of parents will say, you know what, I started them on this medication and they're not sleeping as much or they're not eating as much, right? We can change meds, or what I can do is I can have them space it out a little bit earlier. Instead of giving your meds at 9 o'clock, try to give it at 7 if you can. Or we even have nighttime meds now. You can give it at bedtime, actually, and it starts working in the morning. These are newer meds. Let's see what the next question is. So would you agree with treating the drug use first? Actually, no, I don't agree with treating ADHD with drugs first, right? I always try to use behavioral interventions first, especially the younger the child is. I think the youngest that you can treat someone with medication is 6 years old by FDA, right? Anyone who treats them younger than that is using it off-label, and that's on them. And if anything happens with that kid at that age, it's a lawsuit. So I don't feel comfortable doing that. What do you think is the most ethical approach for a patient who is experiencing seizures due to struggling with alcohol? That's a tough question. So I would have to treat the seizures, right? Whether put them on Depakote or lamotrigine, and try to get them. If they're at that point where they're having seizures with alcohol, they should really be in a detox unit. They should be admitted, because alcohol can actually kill you. And if you don't manage the titration of so a lot of people who are withdrawing from alcohol, we give them a benzodiazepine that is cross-tolerant. So technically, benzodiazepine is actually chemical alcohol. So the reason why when someone takes too much Xanax, they feel kind of drunk almost, is because you're technically giving them synthetic alcohol. So when the body gets used to a certain alcohol level, your neurons kind of adapt to always having that alcohol in its place, right? So chronic alcoholics, they always need that morning drink, right? No, I don't feel awake because I don't drink in the morning, right? I feel like crap when I don't drink in the morning, right? Because your neurons have adapted to that. When you tell them to stop, you know what, stop drinking, or you remove the alcohol from them, your neurons start searching for that alcohol. And again, that tolerance, that sensitization that I was talking about takes effect, and it gets more sensitive because your neurons are chasing that alcohol. Like, where is it, right? Which causes the opposite effect of what alcohol does, which chills you out. It actually makes you more excitatory, which is what a seizure is, right? Excitatory state is pretty much what a seizure is. So what you need to do is you need to kind of taper them off. So what I'll do is, depending on how much alcohol someone's been drinking, I'll start them on a benzodiazepine, whether it's Librium or Ativan, and then I'll taper that off slowly in like a month, right? It's a very slow process. I don't feel comfortable doing it on an outpatient basis, which is why if someone was having those symptoms, I would just refer them to a detox. When I was working inpatient, we used to do these on an inpatient psych unit, and even then we had problems with them because people tend to, what's the word, they underestimate their true alcohol use. So you never want to give them too much benzodiazepine, but at the same time, you don't want to take their word for how much they're actually drinking, right? Okay, next question. How do you differentiate among ADHD, severe anxiety, and trauma? How would you treat meds prescribed for ADHD? That's a very good question, actually. So a lot of times, ADHD and anxiety do overlap, and a lot of our symptoms do kind of overlap. But when I treat nurse practitioner students, I don't like to diagnose people with many different illnesses, right? Because anyone who's diagnosed with bipolar disorder can easily be diagnosed with ADHD, right? There's a joke that we make in psychiatry. Every kid who has bipolar disorder has ADHD. It's just part of the disease, right? It's cognitive dysfunction, right? Same thing can be said with MDD also, major depression, right? People who have cognitive dysfunction, right? So what would I do first? If someone has severe anxiety, right, and trauma, number one, I would probably try to figure out what that trauma was, what the extent of that. Try to get rid of that trauma first and see what's, because trauma, you don't need to hit someone with heavy medications, right? I don't need to give you an SSRI. I don't need to have to give you a stimulant, right? Whatever's left that can't be kind of helped by that trauma processing, then I'll treat the anxiety. And I'll assume that the inattentiveness is part of the ADHD symptom, especially if it's only happening in the context of anxiety, right? I'll ask someone, when you have problems focusing, is it because your mom is next to you while you're in school, right? Is it because you feel that your professor in Zoom is staring at you, or you feel like students in school are staring at you, right? Is it because you're outside and you're worried or whatever it is, right? ADHD is a little bit different. ADHD is more chronic, I believe. It's not as episodic as anxiety, even though anxiety can, but ADHD, you have the cognitive dysfunction and the hyperactivity without having that anxiety aspect of it, right? The heart is not racing, they're not worrying, they're not having tremors, right? Which could be hard, right? Now, sometimes, what do you think would happen if you give someone, if I didn't diagnose, if I missed that anxiety disorder and I treated someone with ADHD, right? And I gave them a stimulant, but in reality, they had anxiety. What do you think would happen?
Could have an adverse effect.
Yeah, their anxiety would get worse.
Yeah.
Their anxiety would get a lot worse. Yeah. So if someone says, you know what, I took that Ritalin, I took that Adderall, and now I can't even, I'm even more worried. I'm more scared, right? Now I'm having panic attacks. Then you know what? I know I messed up. I should have looked at GAD first. Treat the GAD. The ADHD doesn't go away. Then you treat the ADHD. ADHD usually is at the end of the algorithm. So we always treat the bigger umbrella, right? If someone has schizophrenia, I'll treat that first. If someone has schizoaffective disorder, I'll treat that first. Then I'll treat the ADHD, right? Because you can easily go diagnose crazy. Someone has schizoaffective disorder, sure, I can diagnose them with GAD. I can diagnose them with ADHD, right? Which is why you see a lot of patients when they get referred to us, you'll look at their history of diagnosis, and pretty much a kid who's been treated at a young age, and when they become an adult and they see me, I see it's almost like reading the DSM. They have every diagnosis, right? And what does that do? Nothing. It doesn't really benefit the client, right? Sometimes, yes, Diane, you do see anxiety immediately because ADHD medications work very fast, right? Which is why when parents are a little hesitant about starting medications, right? I can say, you know what about we compromise? I'll give you a week supply, right? Because in a week, you'll definitely know if it's working or not. And if they do have side effects, the medication goes out just as fast as it goes in. So if you notice that they're having stomachache, headache from it, once the next day, don't give them that second dose and the side effects should go away, right? It's a little bit of low risk. So I don't prescribe ADHD meds for a month. I usually do a week trial first. I'll follow up with them. I'll ask the parent, if there was some response, and of course I'll see them a second time, and then I'll increase the dose very slowly. Slow titration, right? Slow increase over time usually kind of reduces a lot of the side effects of medication. Anyone want to ask me? We'll do one more. Any other diagnosis that they want to be broken down? Or is that good? Good. All right. Next one. Next slide. All right. How do some of the medications work? So I'm kind of repeating because I kind of covered a lot of this stuff. Antipsychotics blocks dopamine, right? Receptors in the brain. Now, why do you think antipsychotics cause a lot of side effects? I want to take a guess as to why it causes a lot of side effects.
It stops other function that's connected to the frontal lobe.
Yes, that's true. So if you can remember that first slide that I showed you, right? The problem with medications that we have is we're not able to make medications specific. When I say specific, if I could find a way to create an antipsychotic to block dopamine only in that mesolimbic area, I wouldn't be here right now. I'd be a billionaire, right? But the problem is we don't have the technology to do that right now, right? So what happens when you give someone a medication, in essence, it's pretty much throwing a wet blanket on someone's head, right? It touches the whole brain, right? How can I block dopamine in one part of the brain, but not touch it on those other parts of the brain, right? The side effects are because it's touching parts of the brain that I don't want it to touch, right? Now, genetic plays a big part of that also. Some people tend to have more dopamine receptors in their mesolimbic area. So therefore, if I give them an antipsychotic medication, it'll help their psychosis and they won't have as much side effects, right? Depending on your chemical structure, your genetics, right? Your life experiences, right? Our brain changes. Did you know that our genes that are expressed when we're kids still change to this day. Did you know the medications that we're taking are constantly changing our brains? Did you know that epigenetics, which is a new study now, we're realizing that our genes are constantly changing, right? Which is why that explains why some medications work and sometimes they don't, which also explains why sometimes patients who don't have a family history of schizophrenia or bipolar disorder, right, which are highly genetically bound, still get the illness, right? Even if you trace it back, that's because the genes change, right? Whether it's an infection perinatally while the mother was giving birth to them, right? Whether it was the mother drinking alcohol while they were having them, whether it was the mother having a complicated surgery and all the cortisol levels from all the stress caused a change in that environment, right? Whether it's when they were 5 years old, they were touched inappropriately by their uncle, right? Or whether or not other stressors, right? They weren't taught active coping skills at a young age. Our brains, our neurons are always changing, right? So in a way, it gives us hope that if we could find a mechanism to change those genes back, to express genes when they need to be expressed, to quiet genes when they need to be quieted down, we can actually help our clients, right? So it's very important. That's why I always tell clients, if you have a family history of psychosis, schizophrenia, bipolar disorder, depression, anything, please do not smoke marijuana, right? I know a lot of your friends are smoking it, but once you smoke and you awaken those genes that have been dormant, right? Sleeping genes, I can't guarantee that the medications I give you can quiet those genes back, right? Sometimes they can, right? And it's just substance-induced psychosis and it goes away in about 2 weeks. And other times, you can't put the cat back in the bag, right? It awakens those genes. And unfortunately, now you're going to be on antipsychotic medications for the rest of your life. I've seen it quite a few times, especially with synthetic cannabis, K2, right? Because K2, we can't even test for it, right? It needs to be sent to a special lab. It's very expensive. And there's so many different strains of it because people are making it in their basement. They're putting rat poisoning, they're putting potpourri, anything. I don't even know what they're putting in there. And we don't know the exact mechanisms of it. So therefore, if you don't know the mechanisms, I don't know how to treat it, right? Which complicates things. Okay, chat. Let's see. What do you think some alternative practitioners, I believe, in using dietary modifications to treat ADHD? You know, I don't know too much about dietary modifications to treat ADHD, Gloria. So unfortunately, I don't know the answer for that. I'm sorry. But I know for depression, Mediterranean diet is very good, which is high in nuts, olive oil, fish, seafood, low in red meats. That's very good for depression and anxiety. Let's see. What are ideal medications for clients with borderline personality disorder? Okay. Borderline personality disorder. Very tough presentation to deal with, right? Especially in therapy session. Medications tend to not really respond to borderline personality disorder, and borderline personality disorder can actually mimic a lot of many other illnesses, right? Many times it can be confused for bipolar disorder, which happens a lot, right? Because they do cycle, but borderline, they tend to cycle very quickly. So what I'll do is I'll have a client kind of draw a chart for me. You know, in a week, can you kind of draw squibbles of the wave, like up wave is mania, down wave is depression in a 1 week period? Someone who has borderline personality disorder, they'll have many shifts in mood changes. And most of the time it has to do with situational, right? I felt with my girlfriend, I felt with my boyfriend, I felt like my friends don't want to talk to me, they hate me, right? That's when things will change, right? Also, it can, very complicated borderline personality disorder can also look like schizophrenia, because there's something called micropsychosis, which we're only kind of starting to understand now, which their trauma from their borderline personality disorder actually causes changes in which they'll have auditory hallucinations. But the auditory hallucinations are more situational based, right? So if you break up with someone or you believe that someone's leaving you, the voices will tell you that person hates you, and it'll constantly kind of tell you mood congruent psychotic symptoms, right? As opposed to schizophrenia, which can be almost anything, right? Medications, borderline personality disorder. There have been tests that show that some mood stabilizers work for it. But right now, I think the best medication that's been studied for it that has shown positive results, but actually needs more studies. It needs actually randomized double-blind placebo-controlled trials, which is like the gold standard. They have used open-label trials on it, which means that the patient knows that they're taking Lamictal. So when someone takes it that way, how do I know that they're getting better? Because they know they're actually taking Lamictal as opposed to the placebo medication, right? There's bias there. But I do prescribe lamotrigine to patients who I believe have borderline depressive disorder because it does kind of help regulate their mood swings, not as much as if they had bipolar disorder, but enough in which it's controllable and that therapy can kind of be more effective for them, right? So lamotrigine right now is probably the best medication for borderline personality disorder. And for their micropsychosis, antipsychotics typically don't really do much for that. So if someone does have micropsychosis and they're not responding to antipsychotic medications, I would start to lean more towards a personality disorder, right? And for bipolar, that's so interesting about changing gene expression. Okay. Bipolar disorder. So there's a very big push now for bipolar disorder to be diagnosed as a bipolar spectrum disorder. So there's really this big push, the same way we did with schizophrenia. It's very hard to categorize people in bipolar 1, bipolar 2, and classify distinct periods of MDD, distinct periods of hypomanic episodes, and distinct periods of manic episodes, right? Does anyone else have that problem, right? A lot of times they'll kind of mention both. Yeah, I feel sad, I feel down, I have no energy, but I do have racing thoughts, right? Is it anxiety or is it hypomania? I have been a little impulsive. In the past week, I had like 4 sexual partners. I spent a lot of money, right? But I do feel depressed, right? So back then, there was a disorder called MDI, manic depressive illness. You guys remember that? That was from like DSM-2. That captures, I believe too, a lot of people, there's different schools of it. I believe that DSM-5 now, by making it more pragmatic and making it a little bit easier for us to kind of classify people, doesn't give the clients a good clinical picture of what they're actually suffering from. A lot of the clients, especially children, they suffer from mixed, right? So they'll have depression and they'll have mixed features of mania, whether it's impulsivity, meanwhile it's irritability, whether they're sleeping only a few hours, right? And who's to say that 4 days is an adequate amount of time for it to be a hypomanic episode, right? Or 7 days is a clinical amount of time for it to be a manic episode, right? These are all arbitrary, right? There were studies that were shown to kind of help distinguish, to make it easier for us. The DSM is great. I do use it. But when it comes to treatment, I don't rely on it too much, right? For me, I treat more of the symptoms. So just going back to being a spectrum disorder, a lot of bipolar would be best described in a spectrum. So some people might have 70% depression, 30% mania, or 80% mania, 20% depression. It's not really cut and dry. Now, how does that apply to me? That applies to me because if I give someone an antidepressant and they have sub-threshold manic episodes, right, or manic symptoms, what do you think that will happen? What will happen? Have you guys ever seen that? Anyone want to chime in? It'll make them worse. It'll make them worse, right? Think about it. Mania, right? In theory, simplified, it's a little more complicated this. They have too much dopamine, right? They have too much serotonin. They have too much norepinephrine, right? Which is why antipsychotics work for them, or mood stabilizers, right? Now, if I just assume that they have depression and I give them an SSRI because, I don't get a good history, I can trigger a manic episode. I can trigger rapid cycling, right? Which is why the FDA has that black box label that says, if your patient is on SSRI medications, be warned that there might be an increased risk of suicidal ideation, right? Why do you think that is? Imagine feeling depressed and down, and someone gives you an SSRI, and you're irritable, and you're angry, and you're depressed, and now you feel this boost of energy, right? But you still feel suicidal, you still feel depressed. Of course, that's going to push you over the edge, right? It happens. So what I try to do is, once I notice mixed features, I automatically stay away from SSRIs. Automatically stay away, because the risk is not worth the benefits. I understand SSRIs have the less amount of side effects, right? But then it goes back to the argument. Efficacy versus tolerability. Sure, you can tolerate it, right? But is it effective for what I'm treating? No, it's not. So then I would try to use an atypical antipsychotic, right? Like aripiprazole or quetiapine. Again, the overlap, because that can actually help with mixed symptoms of depression and anxiety. Another thing we should know is that since I treat children also, many times, anyone know the median age of onset for depression, for MDD now? When is MDD typically found? When does it really come out in people? The age. You want to take a guess?
Adolescence?
Actually, no, 20s. In
Oh,
20s. Yeah, 20s. Yep, a lot older. We don't really know why people are getting depressed being diagnosed. So at the clinics that I work where I cover children, I see a lot of children that are 13, 12, 14. Back in the day, they actually even believed that you were too young to feel depressed. Back then, when it was more of like a Freudian-based depression, they were like, "Oh my God, your functioning in your brain was not enough. How can you be depressed when your brain is not fully developed yet, right?" But now we know that's false. Kids do have depression, but depression that's diagnosed at a younger age kind of makes you more cautious whether or not it's more a bipolar depression. Because remember, bipolarity is diagnosed younger, right? And a lot of times bipolarity, we only see them when they're depressed, right? Because hypomania can feel good for a client and they might not present with any, they won't come to us when they're hypomanic because they feel great. So a lot of times we'll only see that depression, but then I'll have to get like a history from the family. You know what? Even though, Juliet is complaining of depression now, have you ever noticed the opposite of depression, in which she was talking faster than usual, or she was only sleeping a few hours, right? When you took her to her last psychiatrist, what medications did they prescribe her, and did it work, right? When they tell me, you know what, Juliet's been on Prozac and Lexapro, and it only made her worse, so I stopped it. So I'm wondering, what did it do to her? Did it make her not sleep as much? Did it make her more energetic? So that kind of gives me an understanding, maybe this is more than a major depressive episode, right? Lithium is a great medication for this. Unfortunately, due to the pandemic, it's very hard for me to prescribe it right now because clients are having a hard time getting blood work done. So when things go back to normal and I'm at the office and I'm able to order blood work a little bit easier and I know clients can actually go, lithium would actually be the best for that, right? I know a lot of people are afraid of lithium. It does have side effects to it, but I think the reason for the side effect is because sometimes the providers are a little bit too aggressive when it comes to dosing. Lithium can actually be dosed once a day, which is kind of a new guideline now. It used to be that lithium would be dosed twice a day. In my practice, I will always dose medication once a day, right? The reason why is I would rather you get the medication once a day, even though I know that twice a day might kind of help you a little bit more, but the chance of you not taking that medication is a lot higher, right? So why not dose it once a day? It's more convenient. There's less chance of you missing that medication. And even if it's once a day dosing, once it hits steady state, right, which is about a week, that means that there's stable blood levels of the medication. It doesn't matter if you're getting it once a day or twice a day. Twice a day dosing is really only important that first week, if even that important. Most medications have such a long half-life. Half-life means that the amount of medication, time that it takes the medication to leave your bloodstream is about 12 hours, which is about a day. So it takes 24 hours for it to leave your system. 12 hours, half of it's gone. I can dose every medication. Lithium can be dosed once a day. If you dose lithium once a day, it also alleviates a lot of the side effects, right? If it makes you tired, it's fine because you're taking it at night and it helps you sleep anyway, right? Next question. Can you please elaborate more on the changing genes? That's kind of a complicated topic, and I could probably talk about that for about 2 hours or more. But just know that our genes are constantly changing in response to our environment, right? To our interactions with people, to the medications that we eat, the foods that we take, and the molecular level, right? Therefore, by understanding that, it helps us formulate a good treatment plan for a client in which we're not just giving them medication, we're also teaching them to, continue going to therapy and also practicing healthy lifestyle choices. What do you think about cannabis-infused products? Okay, cannabis. So marijuana is actually, when I say that marijuana is bad for you, I'm talking about marijuana that has THC and cannabis, CBD, right? A lot of the products that we see right now only have CBD, which is the non-psychoactive part of marijuana, right? Which is why it's safer. So a lot of the strains of marijuana, K2, which causes psychosis, the paranoia, all of those feelings that make you worse, that make you more anxious, it's because the proportion of THC is actually a lot higher than the CBD. So the higher the CBD content, actually, the more protective it is against the THC. So if you just take CBD, you're fine. It actually has calming effects. It has anti-anxiety effects, which you see it a lot more. The problem is people who still want to use marijuana, which still has THC in it, that is kind of the problem. Because THC, we also have endocannabinoid receptors in our brain, which are not used to THC, which is synthetic, right? Or even though it's not, or it's grown from a plant, our body's not used to having that external source being put in. So that's what can cause those changes in our brain, which can actually cause psychosis, depression, anxiety, whatever it is. But CBD is safe. THC, no good. I had a patient experience a manic episode and then followed by a hypomanic episode. Yep. So mania trumps hypomania. So once someone has had a manic episode, that they're pretty much already bipolar type 1. So it just goes in severity, which kind of even argues more closer to the spectrum model, right? Instead of saying, you know what, this person is bipolar 2, right? Because they've only had hypomanic episodes, or they're bipolar 1, or they're MDD. It's easier to put them in a spectrum model, because then you can kind of, the reason behind the spectrum model is also because people are prescribing SSRIs way too much because the convenience of prescribing it, especially primary care doctors, because once they see depression, they're like, you know what, Prozac, right? Or Zoloft. And people aren't being referred to specialists like me to really do a better thorough understanding of what's going on there, right? I have a client that all these symptoms, I just refer them to a psychiatrist. I find out what diagnosed soon, but I suspect it's bipolar, okay? He is taking hydroxyzine, Zoloft. I'm using psychoeducation and a bit of CBT. All right. So I've had a client who I suspect has bipolar disorder, and they come to me and they're on hydroxyzine and Zoloft. First thing I would do is I would stop the Zoloft, right? I would stop the Zoloft for about 2 weeks, and then I would say, I want you to come back to me in 2 weeks, and I want to see how your symptoms are, right? If you tell me that your symptoms are better, this is assuming they're not suicidal and they're not a danger to themselves or others, and they can actually wait 2 weeks to see me again. This is more conservative and to help me kind of get a better understanding of the disease process. And if they get better on the Zoloft and they say that their symptoms are actually a little bit better, then I would suspect that they're closer to the bipolar spectrum, right? And then I would give them their options. Would you like to start a mood stabilizer, right? We can do lithium, but the problem with lithium is that you would have to do weekly blood work for a little bit just until you get on a stable dose, right? Or I can put you on an antipsychotic medication, but the problem with that is you have long-term neurological problems later on, like tardive dyskinesia, or you might have weight gain. Lithium can cause weight gain also, but I believe that the metabolic effects of atypical antipsychotics tend to be a lot worse down in the future, all right? For that patient that you think is bipolar, I would write a very specific breakdown of what bipolar symptoms you've seen. The psychiatrist sees it, you kind of have a better understanding of what to look out for, right? Let's see. Do you have any experience with natural lithium, elemental lithium? Okay, interesting. So lithium, actually, all lithium is natural. So lithium is a natural element that's found in certain, what do you call those, wells in certain parts of the country. So actually, certain water supplies in the country that have higher levels of lithium actually have lower suicidal rates and lower homicidal rates, right? So low dose lithium actually is good for you. So low dose lithium, I'm talking about 0.3 milligrams, right? For us to take as a supplement. There was a time, so I actually read a book, and I sound like such a nerd, but I read a book on lithium, which I thought was interesting, and it broke down how it was made, and many times it was pulled on market, put back in the market, and all the studies about it. And there was a time where lithium was actually sold in stores. If you guys didn't know already, 7-Up, it was actually had lithium in it, had lithium carbonate. The reason why they were putting lithium was they thought that lithium was a safer alternative to sodium chloride, which is salt, because it caused less sodium retention. It will kind of, you know, like when you have a lot of salt, it can cause high blood pressure, it can cause all those things, right? And they thought that lithium chloride was a safer alternative, but they didn't realize was that they were putting so much into the regular supply that people were getting lithium toxicity, right? Lithium toxicity, I'll explain it to everyone right now very easily. Lithium, lithium. This is how I teach my students, all right? So L stands for leukocytosis, right? Which is a decrease in white blood cell count, right? I means increase in urination. A lot of patients on lithium. Problem, I hate the lithium because I always have to get up in the middle of the night because it makes me pee so much, right? I pee a lot, right? Because lithium is a salt. Your body kind of balances salt and water. It makes you pee a lot more, right? T is tremors, right? A lot of people, you know, I can't take the lithium because, you know, I'm an architect and every time I try to draw, I'm very tremulous, right? H stands for hypothyroidism, right? Because it can also drop your thyroid, which is very important. I always check thyroid functioning every 6 months, right? And M is metabolic issues, right? So M is, it can cause a little bit of weight gain, right? Going back to lithium salt and the lithium that we have right now, they're pretty, the only difference is that the lithium that we have here is made in that it's made in a capsule that kind of works longer over time. The lithium salt that you take kind of only works for a few hours, and you can't really dose it once a day. So for convenience, I dose people with lithium ER, extended release, less side effects, and it kind of works a little bit smoother. Let's see, any other questions for me? All right, next slide. Common side effects. All right, so these are some of the side effects, and I'll kind of mention how I deal with them. So sexual dysfunction, right? Very, very big side effect that a lot of, I don't blame you. So people will come to me, you know, I don't feel depressed anymore, but I have this issue because I can't get it up, right? So sometimes what I can do is I can add Wellbutrin, which works, but the problem with that is that it takes a long time to work. So a quicker solution, which some of my younger clients, right, like, is I just prescribe them Viagra, right? And then if they want to change meds, we'll change meds. And sometimes some meds might not cause it. The worst medication to cause sexual dysfunction amongst the SSRIs is actually Paxil. I hate Paxil. I don't use Paxil. The reason why I hate Paxil is because, number one, it has a very bad withdrawal syndrome, right? Patients who are on Paxil for a long time, they can't get off it. The body's so used to it. It's the mechanism of Paxil, and they have to kind of stay on it. And it takes me about a year to titrate them off of it. And then the side effects are almost unbearable, right? Weight gain, lifestyle choices, diet, exercise. I can also prescribe metformin, low dose, about 500 milligrams twice a day. That can also help with weight gain. The issue with metformin is that you have to really start it with treatment. So people are kind of hesitant because they're like, you know what, I don't have diabetes. Why are you putting me in metformin? But then if they wait until the weight gain comes and then you put them on metformin, it actually doesn't work as good anymore. So if someone's on a medication that causes a lot of weight gain, if you start the metformin at the same time they're on the medication, then it'll work. It'll prevent it. But it kind of won't really, it won't decrease it. Is metformin bad for the kidney? A lot of medications are bad for the kidneys, right? Which is why it's important to do regular blood testing. If you start the medications at a low dose, you kind of give your body a chance to adapt to it. If I prescribe you metformin 1,500 milligrams, one shot a day, sure, it'll definitely hit your kidneys, and there's a higher chance of you having problems with your kidneys. But if I start you with metformin 500 milligrams once a day, then twice a day, and then so forth, the side effects are a little bit less, right? Sedation, big problem, a lot of our medications, which is why I dose most meds at nighttime, because you want to be sedated at night anyway, and it helps you sleep, right? Worsens insomnia. Did you guys know that a lot of the SSRIs actually worsen insomnia? It's one of the complaints that we get on the medication. Some ways that I address it, I add trazodone at bedtime, so I can add either 25 milligrams or 50 milligrams for insomnia, and it kind of has a synergistic effect. Synergistic means that it kind of makes that medicine work more efficiently. Now you ask, why don't I just prescribe both at the same time if that was the case? It's because I try to stay away from polypharmacy, and if I start you on 2 meds and then later on I want to start you on another medication, then you're on 3 meds as opposed to only 2. And I want to wait until you really need 2 meds before I start 1. Sometimes I'll try the more benign issue, especially if it's a child, right, younger than 16. I'll try melatonin, 5 milligrams. Melatonin, if you do melatonin higher than 5, it actually is not as effective. So you see in stores now, it's called melatonin extra strength. It's like 10 milligrams. 10 milligrams is way too much. It's actually not going to make you more tired. 5 is the sweet spot, between 3 and 5 milligrams, right? Apathetic syndrome. That can happen with SSRIs and actually can also happen with selective serotonin reuptake inhibitors, right? The mechanism is the fact that serotonin is actually serotonin affects dopamine. So by increasing serotonin, you actually block dopamine, right? So in essence, by increasing serotonin in some parts of your brain, you're blocking dopamine in the frontal part of your brain, which can cause apathy, right? Which can cause like a flat affect, right? Blunting of their affect. So once you notice that, if you notice that in any of your clients that I'm treating, please let me know, because then I can address that by going lower on the medication. Usually it's reversible. It just takes a little bit of time, right? Headache is one of those transient symptoms. So headache and stomach ache, you notice that as a side effect of every medication, right? But those are transient. That means that it goes away over time. If you dose medication slowly with foods, usually that goes away if you're able to get it with food, right? Increase in anxiety. This is very important with SSRIs especially. So if I'm giving someone an SSRI to treat anxiety, I always tell them during the first week to 2 weeks of treatment, please don't be afraid if your anxiety goes up at first, right? That just means that your neurons or your brain is adapting to the medication, and that after about 1 to 2 weeks, you should start feeling your anxiety going down, right? Now, what I usually do is if they're still like, so it's like a catch-22, right? Someone who's anxious, who's already hesitant about starting medication, and then you're telling them that you're going to give them a med that's going to increase their anxiety for 1 to 2 weeks, right? That sounds like it's a difficult sell to make. So what I usually do is I'll say, you know what, I'll prescribe you a benzodiazepine for about 2 weeks. If you really are that anxious, it'll work right away. Use it for 2 weeks while the medication is working. Once the medication starts working in about 3 to 4 weeks, right, it starts going down, then we can start increasing it, right? Okay. All right, someone asked, how do you treat the side effect of a flat app? I'm sorry, someone asked a question? No? Okay. How do you treat the side effect of a flat affect?
Can you review that one more time?
I'm sorry, sure, which one?
The impact of like when you introduce an SSRI and a patient gets the flat affect, how would you follow up with it?
Sure. So apathetic syndrome from a flat affect, if you withdraw or lower the SSRI, it usually goes away. If that dose, let's say for instance, they're stable on, let's say Lexapro 20 milligrams and they're hesitant about stopping it because they know that it's actually helping the depression, I can add a medication like aripiprazole, which is a D2 partial agonist. So remember in the beginning of the lecture, I mentioned it's a partial agonist. So it kind of gives a little bit of dopamine into that neuron. That little bit of dopamine might be enough to kind of counteract that lack of dopamine of the SSRI, and that should help the flat affect. All right.
Do you have any suggestions for a patient that has a bipolar diagnosis and when an SSRI is introduced, they get a flat affect and an increase in lethargy and anhedonia?
So if someone has a bipolar disorder, number one, I don't think they should be on SSRI, right? No studies have shown that it's been effective. And if anything, at best, studies have only shown it doesn't do anything. So if someone is stable, right, technically with a SSRI and they're diagnosed bipolar, I would question that diagnosis and wonder if it's actually not just major depression with anxious distress, right, which also can look like that, right, if it's not actually worsening the bipolar disorder. The flat affect, if they have bipolar disorder, you can also add aripiprazole, which is FDA approved for bipolar mania and bipolar depression, and in theory should kind of kill two birds with one stone. So that's an option that the psychiatrist can try. All right, did I answer your question?
Yes, thank you.
Okay, so worsen mania goes back to SSRI use, right? Another hypothesis that we have about the reason why some patients might be suicidal is because of that, right? What I was mentioning about the mixed features. So someone who has depression, we'll say depression, and you give them an SSRI, you worsen mania, right? Which is kind of like, I like to ask patients in a more direct term, like, have you ever felt wired and tired? And it's kind of like an informal way of saying, have you ever felt depression and mania at the same time, right? Have you ever felt wired and tired? Like your mind is wired, but your body feels tired and you just can't sleep, right? Do you have increased goal-directed activity, right? But you're kind of tired at the same time, right? Those are mixed features. Sometimes those features, dysphoric mania is actually a lot worse than euphoric mania. We don't really see a lot of euphoric mania anymore, right? Some of the hypotheses behind that is because we've been using SSRIs so much that it changed the expression of those genes. Did you know that SSRIs are the most widely prescribed medications in psychiatry, right? So if you give enough people SSRIs, even patients with bipolar disorder, in theory, you're changing those genes. So maybe that's one of the reasons why we don't really see euphoric mania. We do see them, but they're not as much as before. You don't really see people say, I feel amazing on, man. A lot of times you see a lot of like, I feel like crap. I'm down, I'm depressed, they're complaining depression, but at the same time, they're doing submanic stuff. They're impulsive, they're irritable, they're angry all the time, right? Another theory about increasing suicidal ideation, what I think is important with us, is because as major depressive disorder, it is an umbrella disorder, which has a lot of components to it, right? So if I talk about depression, you have low mood, you have, low interest, you have guilt, you have low energy, you have poor concentration, right? The neurovegetative symptoms, sleep, appetite, all that stuff. A lot of that doesn't go away all at the same time, right? Most of the times, the neurovegetative stuff goes away, right? Energy, sleep gets a little bit better if it doesn't worsen, right? So imagine someone who is depressed, is suicidal, takes the medication in 2 weeks, their energy got better, right? So now they're actually going to go through with it because they still feel suicidal. Now they have the energy to actually do what they're going to do. So that's why it's important when you're first starting an SSRI. I do it myself when I start someone. I always see them 2 weeks afterwards. If I know they're not following up on appointments with you, I actually want to see them a week later so I can actually assess them to make sure that they're not getting worsened by the SSRI, right? Antipsychotics, blocking D2, right? So one of the most common side effects is called dystonia, right? Remember I mentioned before that dopamine is very important when it comes to fine motor movements, right? Also for muscle movements. So once you block dopamine in the nigrostriatal area, right? That's for movement. People start having spastic movement, right? Or slow movement, or sometimes they even kind of, they get stuck in a position, right? Where they can't move and they need an injection to kind of get them to relax and calm down. That happens a lot in the ER. I remember when I was doing my clinical training in the NYU ER, we had someone come in who tried to overdose on antipsychotic medications because he thought it was something else. And by actually overdosing on, it didn't kill him, but what it does, it blocks so much dopamine. He literally, all his muscles were flexed. And we had to give him an injection of, I believe it was benchtropine, which is an antidote for that. And within maybe 10 minutes, he was back down. He was calm. I'm sure he's not going to do that again. Dyskinesia, involuntary muscle movements, right? So sometimes that can be mistaken for a tic, right? So the key clinical issue with dyskinesia, involuntary muscle movement, and a tic is that a tic is actually suppressible, right? So if someone has a tic and I can say, hey, Mr. Smith, can you stop that? Can you use all of your volitional control to stop that movement that you're doing now? They can do it, right? Dyskinesia, they're not even aware they're doing it, right? Have you ever been on the train and you see the homeless guy who has these weird movements where he's kind of like moving strange? He looks like he's chewing on gum. That's called tardive dyskinesia. Tardive means long-term, right? Long-term dyskinesia. He's been having that for a long time. Most likely he was probably in an antipsychotic. He was probably on heavy antipsychotic medications, and that's unfortunately the long-term side effect of it, right? Akathisia is also very important. Akathisia is probably one of the most overlooked side effects because it can also look like very bad anxiety. It can also look like agitation. On the inpatient floor, sometimes we'll get very violent patients and they'll get an injection, right, of Haldol to kind of help calm them down, right, by blocking dopamine receptors. But by blocking dopamine receptors, you make them feel even more restless because it's akathisia, right? So that's a dilemma that we have. How do you distinguish akathisia from actual agitation? Sometimes, yep.
I was going to ask a quick question. So with the tardive dyskinesia, when they're taking a certain psychotropic medication, like something like Haldol, do they always have to have another component in order to avoid them getting that? Or can they take a strong medication like that and still not get it?
That's a good question. So tardive dyskinesia, we're not really sure who's more prone to it, who's not. But we do know that if someone gets, let's say for instance, someone who's never taken antipsychotics before, right? Actually, most people at risk are actually young African-American muscular males are most at risk for. We don't really know what the genetic component of that is. But if I give you an antipsychotic medication and you develop muscle spasms or dyskinesia, right away from taking it, that kind of makes me more cautious that either I should switch the class of medication of antipsychotic, right? Maybe use a second generation that doesn't cause that as much, or lower your dose because I know in the long term, you might be at higher risk for that. Right. We do have medications now to treat tardive dyskinesia, but they're very expensive. And at this moment, they're not off patent yet. So that means that the insurance companies are able to kind of hold on to the patent and there's no generic form. So not unless I can argue a good case with the insurance companies, most likely they won't cover it. And it's about $1,500 a month for it.
A lot of past clients have taken Cogentin or benzotropic, some type of component medication with that. Is that what you're talking about?
Okay. We just found out recently. So I attended a conference in which we're trying to kind of move away from using Cogentin long-term because we found out that long-term use of Cogentin actually increases someone's risk of tardive dyskinesia in the long run, right? Cogentin is only good acutely. Acutely means in the short term when someone is taking antipsychotic medications and that they're adjusting to it. I don't keep people on benchtropine for a long time. Either I keep them in a very low dose or I start tapering it down. And as the body adjusts to the dopamine blockade, I stop the Cogentin, right? If someone is on long-term Cogentin and every time you stop the Cogentin, they're having side effects from that medication, they really should consider changing the medication because that medication is not for them, right? We have other options. Cogentin actually worsens tardive dyskinesia. If you give someone cogentin and they have tardive dyskinesia, that's actually malpractice. If they had a good lawyer, they can sue whoever continued that benztropine because the mechanisms are very different, and it's proven now that it actually worsens those symptoms. You would have to use another medication, which is valbenazine, which is still on patent, which is very expensive. There are some studies showing Alzheimer's meds that actually kind of help reduce it, but I'll be honest, if tardive dyskinesia doesn't go away on its own after you stop the antipsychotic medication, most likely it's there for life. Unfortunately, yeah. Someone wrote me a question. Did I answer it? Okay, I guess I answered it. Yeah, cogentin, tardive dyskinesia, no good. Parkinsonian syndrome. Parkinsonian syndrome is literally looks like Parkinson's, right? So someone has shuffling gait. They have a lot of times for Parkinsonian syndrome, that symptom comes out very, very mild. So it takes a very trained eye to kind of notice it. How I was trained to notice it is that I would look at arm swing. So a patient who I started on antipsychotic medications, I would keep a mental note of how they walk when they swing their arms, right? Once I start noticing that the arm swing gets less and less, right? Then I start to question, is it because of the medication, right? Then I look at their face. Do they have mask-like faces? People have Parkinson, right? They have a mask-like face. It almost looks like they have a mask on their face, right? Do they have cogwheeling? Cogwheeling means that the arms, when you move it, it moves like a cogwheel to a clock and gets very stiff, right? That could also be from long-term use of antipsychotics, right? Because in reality, you're walking a balance between giving someone a medication that induces Parkinson's, but at the same time, you're stopping their psychosis, right? There sometimes is a happy medium and sometimes there's not. So we do have different options with different medications. We have about 12 different antipsychotic medications that are in use here in the US. And we can always try one over the other. Each one kind of has its different perks and benefits. And then weight gain, same thing, right? Metformin, healthier lifestyle choices. All right. Next slide. Okay. Dr. Yoon asked me to speak about this because I think this is very important. So I'm going to talk about this for the last couple of minutes of the slide. And I think it's very important that we kind of work together. When I was first starting practicing, I was actually a registered nurse first. I worked with a lot of brilliant psychiatrists and I worked with a lot of not so good psychiatrists, right? The difference between the brilliant psychiatrists or NPs that I worked with were that there was not this ego, which the psychiatrist or NP would say, you know what, I am the head of the team. I'm giving this medication because I decided it is, right? I think it's important that we did this because I do want people that work with me to have a general understanding of what the medication is. And if you've worked with me at Child Center, you know that I like to write these little cliff notes about each patient that I see, right? Things that are pertinent. I'll write what my impressions were. I'll always write why I'm putting the medications. And I always give you the rationale. I don't want it to be that there's this mystique about why is Richard prescribing my patient this medication? Why is he prescribing my patient aripiprazole? And the patient is complaining of major depression, right? I'll definitely write it saying patient presents with depressive episode, but has subthreshold mania, therefore SSRIs would make it worse. And that's why I'm giving them aripiprazole, right? I always do that. So I guess the collaboration is that we should always touch base. If I'm seeing one of your clients, I really do appreciate it when you give me a heads up on what's going on with them before I do my full psychiatric evaluation, right? There's nothing worse than when I'm seeing someone cold and I know I'm seeing them, but I don't see like a referral sheet that's on Welligen and I'm kind of just looking at them and I see it says presenting diagnosis, but I don't, sometimes the presenting diagnosis, I'll say, oh, well, it says here you have anxiety. I'm like, oh, wait a second, I'm hearing voices, right? And then it kind of makes me look silly. So then I have to backtrack. So I think it's good that we always kind of collaborate. And if you have any questions at all, I have an open door policy or open email policy. Feel free to, I like the challenge of having tough clinical questions asked of me. If I don't know the answer, I'll tell you straight out. I don't know the answer, or I'll collaborate with someone who does, and I'll get the answer for you. So always shoot me an email, and I'll always answer any clinical questions, even if it's with a patient. That's not mine. All right. I don't like to step on other providers' shoes. So sometimes if you feel like they need a second opinion, please ask that provider if it's okay with them out of respect, because it just makes you feel awkward if like they were seeing them and all of a sudden the case kind of gets transferred to me and then I'm treating them and it just looks a little strange. But I don't think that's happened yet, but just in case. Anyone have any questions about, I don't know, anything at all? We have a few minutes. We kind of touched on a lot. But my goal was to kind of explain this in an easy to understand fashion. If you enjoyed this, and if Dr. Yoon would like to make this on a regular basis every couple of months, I'm more than open to do this.